welcome everyone to the Performance and Audit Committee of the 21st of May. Arlene, do you want to kick us off, please?
Thanks, Chair. Yep. Can I just remind everybody that the meeting is being recorded and will be placed on websites for public viewing. And I'll now do a roll call for the minute. Bob Benson.
Here.
Councillor McHugh.
Present.
Councillor Toland. Oh, I can see she's just joined. I've had apologies from David Cheap and apologies from Dave Berry. Christine Jones.
Present.
Sanjay Pillai. I've had apologies from Glenn Lloyd. Jocelyn Lyle.
Present.
Raymond Marshall. Martin Sloan.
Present.
And that concludes the roll call. Shall I just carry on, Chair?
Yes, please.
Thanks. So that takes us on to item 1, which is apologies for absence, which have already been noted. Item 2, declaration of interest. Are there any declarations? Not seeing any, so that takes us on to item 3A, which is the minute of the meeting held on the 28th of January, which is submitted for approval.
Okay. And any amendments to the minute before we approve? Okay.
Chair, I can see Councillor McHugh has got her hand.
Dorothy, thank you.
It's not an amendment, but under page 3, section 6, 4 and 5. I was to get some further information on a couple of things, and I don't think I've had this.
Do we want to raise these as action points, Dorothy? We could do it as a matter arising, if you wish.
Normally, when an action like that, occurs at the meeting, it does go onto the action tracker, but these haven't. Yeah. And I'm just noting that I don't think I've had these updates that were promised.
Can we note that for the minute then, Ardeen, that these points, Dorothy, you want to send them to Arlene, the points in question, and we'll make sure they're minuted and that they should be put on the action tracker. Is that okay?
Yeah, that's fine. Thank you.
Okay, great. Further to that, can we now move to approve the minute? Okay, thank you so much. Right, thank you very much indeed. Arlene?
So it takes us now on to item 3B, which is the action tracker, which is submitted for noting.
Okay. Christine, is there anything we need to note about this?
No, so we've managed to get a few more actions all completed. So these are noted on there as green, showing that they've been completed and will be removed at the next one. There's the first one's still being sort of looked at in terms of sort of wider capacity across the team, and looking at that one. And there's a few others that are not yet due, so we'll be picking those up over the next few months and then come back to in terms of those. But considerably fewer will be left on the action tracker after the end of today, although noting the comments that we've just looked at from the minute.
Yeah. Okay. Well, that's it's grateful when I first started, so that's grand. Any comments on the action tracker?
No red bits today. Yay!
I can hear you. I always hear your disappointment. Thank you so much. That now moves on to next item. Arlene?
That's item 4, the performance report 2024-25 quarter 3, and this is for noting.
Thank you. And I've got an email here. Can you, Christine, could you remind me who's leading on this today?
Yeah, if I can find my right button. So I think she's leading on this one today, and Lindsay will come in with any particular additional support if there's any questions afterwards as well.
Thank you so much.
Shahida. Yeah.
Thank you. So the purpose of this report is to give the key information on the performance of the national indicators, the MSG indicators and the social work demand data Most of the indicators are for the rolling year, January 2025 to December 2025. We have compared against two baselines, 2018-19 and 2019-20. So the duty under the legislation is to compare the last 5 years. The 2019-20 baseline is affected by the pandemic. So that's the reason why we have the two baselines, 2019-20 and 2018-19. So for the key messages in the data, it's worth noting that there are variation between the 8 LCPPs in Dundee. So emergency admissions has increased by 16.4% against the 2019-20 baseline and 14.6% against the 2018-19 baseline, with every LTPP showing an increase. The highest increase was in the ferry against both the 2019-20 baseline and the 2018-19 baseline. The lowest was in East End against a 2019-20 baseline and the West End against a 2018-19 baseline. So looking at the current data and comparing it to Dundee, half are doing better and half are doing worse. So for emergency bed days, this has decreased by 1.9% against the 2019-20 baseline and 6.8% against the 2018-19 baseline. So this is an improvement. So 4 of the LTPPs shows an improvement against the 2019-20 baseline and 5 against the 2018-19 baseline. So comparing the performance to Dundee, 3 of the LCPPs, North East, Merrifield and West End, had better performance and 5 were worse. So for 28-day readmission rate per 1,000 population, this has increased by 1% in comparison to both baselines. East End showed an improvement against both baseline years, and Coldside had the highest increase against both baseline years. So comparing the LCPP to the Dundee rate, which is 143 readmissions per 1,000 population, 2 LCPPs had better performance and 6 had worse. So hospital admissions due to fall for over 65s increased by 5% when compared to both the baseline years. Coldside and West End showed a decrease against both baseline years. East End had the highest increase against 2019-20 baseline, and North East had the highest increase against the 2018-19 baseline. The Dundee rate was 32 falls per 1,000 population per over 65. 4 of the LCPPs had a lower rate and 4 had a higher rate. So for delayed discharge for standard delays, this shows an improvement against both the baseline years. So for 2019-20 baseline year, every LCPP showed an improvement, but comparing for the 2018-19 baseline year, Coldside and the Ferry show an increase. There were 240 bed days lost per 1,000 population over 75. So for Code 9 delays, the performance was worse against the 2019-20 baseline and improved against the 2018-19 baseline. The Ferry and Coldside had the worst performance against both baseline years. There were 75 bed days lost per 1,000 population over 75. So the numbers are small, so there's greater variations between the LTPPs. Finally, looking at the social care demand data, which is based on a snapshot for 3rd of March 2025, 0 people waited in hospital for assessment and 138 people waited in the community for a social care assessment. So 1 person was assessed and waiting for a care package at home, in hospital, 12 hours to be provided, and 2 people were assessed in the community, 4 hours to be provided. For those already in receipt of care at home, 2 additional hours were required and not provided.
Thank you, Shahida. Shahida, can you just refresh my memory? What is Code 9 exactly?
So that is the more complex delays, and my understanding is, I think it's people waiting for guardianships, and I think Jenny's got a better answer.
Okay, thank you. Thanks very much indeed, Shahida. Jenny.
Yeah, no, Shahida's absolutely right. 9's a complex coding and it can relate to other subcodings. So it could be a coding that's for guardianship, or it could be particularly specialist accommodation with support that go with the 9 code, but the 9 bit just indicates complex.
Okay, thank you very much indeed. Any questions for Shahida, please? Dorothy?
Thank you. I don't know if it's particularly for Shahida, but item 5.1 of this report is headed Key Analytical Messages for the quarter. I'm not sure what the word analytical means here, because what we get under all the bullet points is just a further detail on the numbers, and not any. What I think would be helpful would be some sort of assessment of the numbers that we're looking at. I have a sort of, this is a two-part question.
Well, I tell you, why don't we take that first one?
Okay.
Dorothy, because I actually agree with you, and I'm wondering perhaps that some kind of concluding summary or assessment of what does it mean, so what would really help. So we may be thinking about an exec summary of some kind, I think, like this, what we're needing. But that's just me racing ahead. Shahida, do you want to pick that one up?
Mm-hmm. Yes, I'll make a note of that.
I think that was the answer, Dorothy.
Yeah, yes. Yeah, I think it would be useful to get, why, or, some sort of assessment as to, why the numbers are as they are. Particularly in bullet point 1, 2, 3, 4, 5. If someone could perhaps email me following the meeting, this is the rate of emergency admissions per 100,000 18 plus population, increased by 16.4%. Now, I can't work out, I'm not sure how that's calculated, and I'd like it explained to me, because I've looked at the numbers on the appendix summary, and I can't, get to a figure of 16.4%. But so if someone could, don't waste time at this meeting, but if someone could explain to me how that's calculated. That's not the part 2 of my question. I still have a part 2 of my question.
I see. Thank you for clarifying that, Dorothy, because I was going to say, I think that's what an exec summary would do, would actually start to answer some of the questions you've raised, because emergency admissions is one of the issues that's been highlighted within this analysis. And your second question?
Actually, it's probably more of a comment than a question. Looking at the appendix, the performance summary, I do love a traffic light system because it's really in your face. And what I've noticed over the 3 years now that I've been sitting on this board is the increase in the red boxes. It's quite stark, isn't it? For example, in the first table, 1A, 30 of 54 of the boxes are red. And in table 1B, 29, I just feel this is a worrying trend. So that's really just a comment for anyone that wants to pick it up.
Thank you very much. I've got Lindsay coming in. Lindsay, are you coming in with reference to that point that Dorothy is making?
Yes, it was actually in reference to the first point, if that's okay, about the assessment. We take on board your request for further assessment detail. Of course, I just wanted to draw attention to the annual performance report. Because these national indicators are extremely high level, there's a huge range of cross-system and whole system improvement happening, and it's very difficult to tie each of those improvements across the partnership to those national very high level indicators. So for that reason, we prepare a very detailed annual performance report where we are providing assurance against each of those national indicators, and on an annual basis, that's probably the best report that we have to provide that detailed assessment. But of course, we want to try and provide that information to you on a quarterly basis, but it won't give the same detail as the annual performance report. But we will certainly take on board your request, and we'll discuss it as a team to see how best we can do that for this quarterly report.
Thanks very much indeed. just reflecting on what's been said so far, actually, if I remember from the budget discussions that we had, it was very clearly highlighting that there would likely be increased demand across the whole system. And I think that was one of the, and we're now just seeing more evidence of this as time goes by. And so this is no major surprise seeing these kind of indicators. Martin.
Thanks, Chair. My question, I say the report's excellent. It's a typical report we see over the last number of years. It's always been excellent, but there's one thing I would like to pick up on is on big page number 27, item 16, hospital admissions due to falls rate per 1,000. There's been an increase in 5% in that, in the baseline. And I was wondering, is there any way we can get some more data to indicate where these falls, these incidents are taking place, so we can get a better idea whether we should be giving directions to the council and to the housing, or in terms of street furniture or whatever, just to try to reduce that, because it shows from the last three columns on that table that we are the worst in Scotland, the worst in our family group, and the worst in Tayside. And that, for me, is a very, very concerning aspect of that. And I think we really need to, either with the data we've got already, or try to extract some new data from people to find out exactly how these incidents are taking place and how we can resolve them and get that number reduced.
Thank you. That's I suspect that's going to be quite difficult to get that information. But I've got Matthew. Are you coming in to respond to that?
I'll certainly try my best, Bob. Yeah, thanks, Martin, for the question. We have quite a lot of data across, well, Dundee and Scotland on where people fall and and the different regions where they fall, whether that's a care home, whether that's in their own home, whether that's in the street. And we get very good support from our local improvement support team analysts around where the falls are in the different parts of Dundee. So through the falls group, we are using that data to try and direct some of the work that we do in the community to target areas where we have noticed that there's an increase in the number of falls that there are. Through that group, we also have the care home teams around the table so that we can make sure that the right education, support, awareness for falls and falls management is undertaken for everybody. We're also doing work in the falls service, and we're trying to do this through the emergency department as well, just to try and ask a few more questions about where people have fallen and what might have led them to fall. So, for example, we've spoken in this forum before about things like pavements and lighting, things like that, just so that we're aware of where there might be particular issues that we need to address. So we're doing what we can to highlight that, and we've got measures in place to try and mitigate where possible. The challenge, of course, is we don't know when people might fall, and obviously a lot of people fall for the first time and they're not on our radar as such. Yeah. So it's quite a complex thing to try and manage entirely. Does that give you enough information, Martin, to satisfy your query?
That does indeed. Thank you very much, Ken and Matthew.
Thank you.
Yeah, thanks very much. Lindsay, do you want to come in again?
Yes, please. Thank you very much. I just wanted to note that the relatively small numbers of falls over the year does skew the figures in terms of the rate and the percentage difference from the baseline year. I have some figures in front of me. So the Dundee rate referred to 860 falls over a 12-month period. There is a 5% increase compared with the rate in 1920, where there were 791 falls over the 12-month period. So that's a difference of 69 falls over 12 months, which relative to the age 65 plus population and the sort of the overall number of admissions for over 65s, is a very, very small number, and that is skewing the percentage when we compare with the rate. The national indicator does report rate, so we report rate, but I just wanted to sort of make that clear that that is contributing to that difference.
Thank you, Lindsay. I'm going to draw this to a close now and note to recommendations. I'd particularly like to highlight the areas that are in the recommendations around the people who are waiting in the community for a social care assessment, which I think are quite promising, and the other ones at care at home packages. Again, these are really good figures, I would say. So I think I would like to highlight that out of the recommendations, if I may. And actually, I think the recommendation could have been stronger than that. In fact, I said it was very positive, actually. So, but anyway, that's just my own take on it. Thank you so much indeed. Thank you very much, Shahida. And I'll now move on to so we note those recommendations. Arlene.
Okay, thanks. That takes us on to item 5, which is the Clinical Care and Professional Governance Assurance Report. This is for a decision.
Thank you. And Christine, I've lost that email that you sent me, who's leading on things. Can you tell me who's leading on this, please?
Yes, Matthew's going to pick this one up for us.
Thank you, Matthew.
Right, thank you, Chair. So this is the Clinical Care and Professional Governance Report for the partnership, and we're offering this report at the level of reasonable assurance for the elements listed at section 2.2 on page 37. Just wanted to pick up a couple of things to bring to everyone's attention. The risk landscape, I think, for our higher level risks, which are the risks in the blue boxes from page 38 onwards, is staying relatively static at this point in time. I'll go into a bit more detail when I talk about some of the workforce risks around some of the reasons for those, but that's quite positive in terms of we've brought those risks back down from fairly high levels, but they are staying static at this point in time. The work around risk, though, is staying fairly fluid. We have had 3 risks closed in this period, 3 risks archived, and 3 new risks put into the system. So there's a lot of work to make sure that we're on top of our risks, and we've got a good understanding of the risk profile across the partnership. We do have a new risk that's come through at level 15, which is funding for the Early Intervention in Psychosis Service, which is a new model of care that is being trialled, and the teams are just looking to secure additional funding, having conversations about that at the moment. But that's a new risk that's come to us. At the last committee meeting, we were asked to provide a bit more information in and around the workforce risks. So the table on page 42 is listing our current workforce risks. This number has come down. We're sitting at 13. I think there are now 9. 4, as you can see at the bottom of that table, have been closed. So there's movement into there. But I just wanted to give a couple of examples of perhaps why these figures are staying as they are at this point in time. So I'll just speak to risk 612, which is in our drug and alcohol recovery service. And this is relating to the insufficient numbers of staff with prescribing competences. This has been a risk that we've been working up really for quite some time. It started pre-COVID, and we've moved from a position of having no people with prescribing competences, and we've now got 18 with a target of 21 that we're heading for. So it would stand to reason that with those numbers, we'd expect that risk to start to come down. However, what we've noticed over that period of time is that the expectation on those prescribers has changed significantly. So a good example around there would be the medication-assisted treatment standards that have come through, and the requirement to do, for example, same-day prescribing for those staff. So while the numbers have increased, and that's very, very positive, the expectation and the amount of work and support that we're able to provide to patients has also increased as well. Once we've got the top number of 21 within there, we'll have obviously more staff with those competences, but we'll also have less staff that are training and supporting those staff building up to there. So we should start to see that risk reduce at that point in time. Risk 999, and I've just read this morning in one of the exception reports, because we've got our governance meeting this afternoon, that a consultant psychiatrist has now been appointed to the eating disorder service, which is very positive news, but that's hot off the press, so I was happy to share that. So that risk will also be removed. And then a couple of slightly innovative ways that we've looked at some of these risks. So risk 877, the Tayside Sexual and Reproductive Health consultant role. We've really struggled for quite some time, gone through recruitment process to recruit to this post unsuccessfully, and the service now have appointed a specialty doctor, and through the CSER programme, they've appointed a specialty doctor who will train in post up to consultant level, and then that will manage and mitigate that risk. So they're in the process of working through that at this time. Similarly, for risk 933, which is the Centre for Brain Injury Rehab, which shows you when this risk went onto the system, because we no longer could call that service that name, but we've been unable to recruit to consultant medical staff from the rehab specialty, and there are international shortages for these doctors, and we tried for a long time, to bring people in. But what we've done is we've redesigned within that role, and we've brought in an allied health professions consultant post. It's a physiotherapist, but working as an AHP consultant. That member of staff is in post, but we're spending probably the first 12 months of their time in post to assess the impact that they're having, so that we can understand if they can fulfil the majority of that role and to identify where the gaps potentially sit. And there's a lot of redesign work in and around our stroke and neuro pathways with great support from acute and our stroke colleagues. So it's just a slightly different way of thinking about how we can maybe address some of the challenges that we've got with regard to recruitment and staffing issues that we've got. The only other couple of sorry, just very briefly on page 44, it was just really to bring to attention some of the increase in demand that we're noticing on our community mental health service report, that they've got referral rates are double what they were pre-COVID. They've been there for some time and they're staying there. And our adult weight management service have seen an increase of some 5 times of the referral rate, which is having a massive impact on the ability to deliver some of those services into there. Work is ongoing to manage those and draw in additional resource to support that, but I just wanted to bring that to the committee's attention. Thanks.
Thanks very much, and particularly that final point you were making, just about demand. Thank you so much indeed, Matthew. Questions from Matthew? Dorothy, you're on mute.
Thank you, Matthew. This is just an observation on page 42, which is the workforce risks, I think, isn't it? Yes. I'm looking at the numbers in the first column. The highest number is 1471. Don't tell me that means there are over 1,400 risks in total.
Yes, that's correct. But this is an NHS Tayside system.
Right, okay.
And that's all risks that have been in the system from the start of the use of the system. So that includes a lot of closed risks as well.
Right, okay. Just, I thought, oh my goodness, 1,500 risks, what we're going to do. Right, okay, yeah. Sorry. Page 43, clinical and care governance arrangements, and that tells us about these meetings where we get exceptions report and or speakers. And I'm wondering if there's a particular problem with psychology. So it seems to be the worst performer in terms of presenting a report or providing a speaker. 3 times out of 7, no report and no speaker. Should we be concerned about that?
Well, yes, we are a little bit concerned about that in terms of not having the conversations within that meeting and that at that time. We do know that we've got very good support through our psychology director, who leads the work and the governance work and the development work across the service. So we have a degree of assurance that work is done and that work is good. However, we don't have the regular attendance that we need in this meeting. So it's absolutely something that we want to work with the team to make sure that we can address. I believe there has been some sickness absence within that team that's contributed to that. But nevertheless, we really should have those conversations, because that's our main route for assurance through the partnership. I see Jenny wants to come in on that point as well.
Jenny. Yeah, it was just to say a similar thing, Matthew, that you've just covered. That's been a problem with absence, but our clinical lead, Linda Graham, is also the director of that service and has been covering it through her reports in around mental health. So it's not uncovered within the meeting in the absence of it. And just to confirm, the governance meetings are going ahead for psychology.
I think that's a bit where what you're actually saying, actually, the written information actually suggests something else. That's the point that Dorothy's made, and perhaps that's a bit about maybe that part needs to be kind of articulated a bit more in the paperwork. So we're not asking questions that if there's a reasonable degree of colour, that would be really helpful, actually. Thank you for that. That's really helpful. Are there any other questions on this?
I'm afraid so. I have another couple of wee things.
So that's fine.
Page 48, clinical challenging behaviour at C8. I don't understand the numbers. There were 26 events reported, and this is a decrease of 36. I don't understand those numbers.
Okay, so the decrease is at the last report we reported that there were 62.
Oh, right. Matthew, I'm just being stupid. Forgive me.
It's a big drop actually in a relatively small number, and it is quite startling. And some excellent work within that team to do that. But it just means that's the change from the last report. Yeah.
And my last question, you'll all be happy to note, is on page 53 of my bundle. And this is the, what is this? This is overdue verified events. No, it's not. Adverse incidents. Could someone tell me what, there's a table and it's event severity and it goes from 2019 to 2025. And there are figures in brackets in each column. Could someone tell me what these figures in brackets denote?
Yeah, I'll do that, and apologies that there isn't a key to explain that. The figures in brackets were the figures from the last report. So if we look at the 2019 column, there were 2 adverse events that were mortality learning events, purple, and this time there are none.
Right, okay.
So apologies, I'll amend that to make that clear, Dorothy.
That's fine. Thank you, Matthew. Thank you.
And thanks very much, Dorothy, for those questions, and thank you, Matthew. Any further questions here? And we're asked to approve the level of assurance is reasonable due to the various factors provided. And are we assured that reasonable is correct? I see a nodding of heads. Thank you so much. Thank you very much indeed. And I think some of the questions have raised some interesting points for inclusion in future reports, Doris. Thank you so much for that.
Thank you.
Okay, Arlene.
Thanks, Chair. That takes us on item 6, which is the annual review of 2024-25, and this is for a decision.
Bob, I'll help you out here. That's for me. I'm picking this one up.
Oh, thank you.
Okay, so this is a bit of an sort of enhancing our internal governance and control and sort of self-assessment purposes. We do need to take a report up to IGB as part of the assurance purposes to provide the IGB with assurance that the PAC has looked at the reports in line with its remit and the sort of governance and internal control processes and delivered in terms of the terms of reference. So 4.3 of the report just summarises the key purpose and remit of PAC and just summarises from the terms of reference. 4.4 summarises the reports that have been presented and scrutinised by PAC during the financial year 24-25. So many of these reports are obviously coming to us on a quarterly basis regularly. Some of them are obviously annual reports. A few of them are just every 6 months or so. That summarises all the reports that have been presented through to PAC during the last financial year. And PAC is basically asked to note the content of the report and also asked to undertake a self-assessment review of the activities that have been undertaken, confirm these are in line with the remit, with its remit, terms of reference, to then allow us to then take a report up to IGB and submit to the IGB for oversight and assurance purposes.
Thank you, Christine. Okay, any questions on this report? Some of it you've obviously been through before. No questions?
Obviously, the chair of PAC did rotate during the 24-25, but I have also shared this with Ken separately, as well as previous chair of PAC during the financial year, and he had no further comments to make on it as well.
Thank you very much indeed. That's really helpful. So do we note and agree the recommendations, and particularly 2.2 confirms activities undertaken, etc., and instructs the report to be submitted to IGB for oversight and assurance purposes? Do we concur with that? Thank you so much indeed. Arlene?
Item 7 is IGB Directions 24-25, and this is for noting.
Thank you. Who's leading on this today?
It's me again.
Oh, thank you, Christine.
Okay, so as part of the IGB's directions policies, PAC has been given the task of assessing the directions that have been issued and ensuring that these have been issued appropriately, timeously, and also implemented in line with the directions policy from the IGB. And this is the first time we're bringing this report to PAC, as the directions policy was only actually approved by IGB just over 2 years ago. So this is like the first sort of full financial year of looking at some of this. So as a summary, 4.3 provides details or summary details of the directions requirements from IGB. 4.4 and 4.5 summarises the PAC's responsibilities in terms of these directions, and 4.6 details all the IGB meetings that took place during 24-25 and where directions have been issued, and an update in the final column as to sort of the outcomes of the progress on these. So PAC is just asked to note the content of the directions that have been issued during the financial year, and that these have been implemented in line, take the assurance that these have been implemented in line with the IGB directions policy.
Thank you very much indeed. I think the report's fairly clear, actually. Thank you so much for that. Any questions for Christine? No. In that case, I'll just move to the we accept recommendations, and we note the contents of this report. Thank you very much indeed. It's great to see the directions policies that have been fully implemented now. It's really interesting just to see how this develops as time goes by, as we move into more complex environments. Thank you very much indeed. Arlene.
Item 8, quarterly feedback report, 4th quarter, and this is for noting.
And Catherine's going to pick this up for us.
Thank you, Catherine.
Yeah, I'll pick this up in Claire's absence, and Claire and Cheryl have prepared the report. Just a briefly, Bob, a very small number of things to highlight. So I'm sure you'll have noted from section 5.2 that there has been an increase in the number of complaints received over the last quarter, and then the following sections at 5.3 and 5.4 that there remains a challenge across whether it's health or social care complaints in terms of being able to resolve complaints within the timescale set out in the policies and procedures. But obviously close monitoring of that process continues, and really I think the main cause for delays beyond the set timescales are around the complexity of complaints, and particularly the significant number of open complaints from mental health, and the challenges around the complexity, particularly of resolving those complaints as well. The only other thing I wanted to highlight to you, just from a more technical point of view, and towards the end of the report, Claire and Cheryl have noted that Dundee City Council has recently changed its IT system that it uses for complaint management. So at the moment, the reporting functions from that aren't available, so we can't report currently on the open complaints from a council perspective, but we expect that we will be able to do that in due course. That's a temporary issue. And there's been quite a lot of training rolled out about use of that new system. So when the reporting function comes online, we'll be able to revert to reporting that to you.
Thank you very much indeed. Questions for Kathleen? Dorothy.
No, just a comment. Thank you, Catherine. 10.1, no complaints about the Integration Joint Board. I'm really pleased to see that. Thank you for including it.
Catherine, if I may ask a question, I noticed that there's a separation of complaints between health staff and social care staff. In an integrated system, how do we identify something that's exclusively health, given that a failing in one system may affect the other, and that would work vice versa? I just wondered how you identify that. And is it relevant to have health and social care separated, and we just have complaints instead? Just a question.
Yeah, I can answer part of this, and Jenny will answer part of it as well. So okay. Initially they're identified in the system in which they come in through, so that is very much about where the complainant lands their complaint, if you like. And some complainants do complain simultaneously in both systems, and we can advise people to do that, and we are very open and transparent about our complaint process. The need for the three complaint systems really relates to the governance, so that's why we have a separate one for the IGB as a separate legal entity, and then obviously in terms of our operational services, legally they are being delivered by the legal entities of the council and NHS, and therefore they're used for those. So it does become a complicated system, but we do try and support complainants to navigate that and really to focus on getting a good response to complaint to somebody as quickly as we can, rather than getting too stuck in which system it comes into or out of. Okay. And Jenny will say more, I think, about the next thing I'm going to say, but essentially I think we are quite good in our integrated teams when complaints come in at recognising, even if it has only come in, for example, through a health system, but we think there is a social care or social work element, that we will identify that proactively and will allocate the complaint and pick it up in the opposite system as well. So we do a lot of that management for people in the background. Jenny, do you want to add to that?
Can I just ask a question? But there's no double counting. So if you've got one case where there's two separate issues, one social care and one health within the same client situation, would that require different counting and complaints?
Yeah, that would be logged twice.
Yeah.
I see. Right. So we have to be cautious about the numbers. Yeah. Right. Okay. Thank you. And Jenny,
we should probably add that as a health warning in the next report, Bob. I'll speak to Cheryl about doing that to make sure that's clear.
Thank you.
I'm not going to add anything to that, Catherine. You've covered that well. We try and manage it as a single response, but record it accordingly. And it makes absolutely no sense in an integrated team to try and pull bits of that out, but the legislation hasn't caught up with that.
Thank you. Well, maybe that's something that could be fed back to Dave as a kind of policy consideration, because I do think it is an important issue for an integrated service, and certainly not double counting. It doesn't make any sense, I think, because it gives a false representation. And just looking at the recommendations, and hoping we'll see more positive information coming through care opinion work when we get a development session on that. Thank you. I don't see any further questions on this. Okay, can we just accept the recommendations 2.1 to 2.4? And thank you very much indeed. That's really helpful, and the report is clear. Thank you. Arlene.
Thanks. That takes us on to item 9, which is the Strategic Risk Register update. This is for Noting.
Again, this is me in Claire's absence. Again, I'll keep this really brief. That there's been no movement in the risk levels since the last report came to the Performance and Audit Committee. There still remain the 4 risks at that kind of maximum 25 risk level around staff resource, capital investment, and 2 that are around financial sustainability issues. Probably then just to highlight to you that I think we've identified as a senior management team that it would be helpful to do a fairly thorough review of the risk register post our 25-26 budget setting process, because there are perhaps different risks or different kind of descriptions or controls around risks as well. So we're going to go through that process at the moment. We've started that, and we do have the IGB's Risk and Assurance Development session on the 11th of June, where we'll be able to give you more information about that process, get some input from yourselves and wider IGB members, and we'll also pick up the outstanding issue around setting risk appetite at that session as well. So there's a lot that's been static in terms of the content of the current risk register, but just so that you've got that awareness that we are working on that in the background and looking at a kind of thorough refresh of it.
So when you're doing a risk appetite exercise, does that mean that you'll write out to each person individually on the board, asking them for their assessment of what the risk appetite might be as a board?
I think that was the intention, that we would do some pre-work in terms of looking at how we categorise risks and setting appetite around categories, and then bring that together. And if there are where there's commonalities, that's great. If there's disagreement about some of that, we can debate and discuss when we meet as well. So we're just planning the content for that next session to be able to do that.
Thank you. And just having done this exercise recently, I found it very helpful not just to ascertain what your appetite is, but also the reasons why you want to have that decision. And I think that's an important part of any individual assessment. So I just thought, from my experience, I found it to be really helpful, and actually makes it it's actually quite a challenging exercise to do that. Yeah. And Dorothy seems to be nodding as well, so that must be right then. Okay, are there any questions on the Strategic Risk Register update? No, just one final comment. National insurance, that's now live. So presumably that's now incorporated into the budget. So that risk needs to be looked at now in terms of your review.
Yeah, and that was one of the ones that we've kind of done a bit of an initial assessment, Bob, in terms of ones that maybe need to be really thoroughly thought through, others that need maybe more just tweaking, etc. And that's certainly on that list.
Thank you so much, Catherine. That now takes us to the Governance Action Plan Progress Report. Oh, sorry, Arlene, I just missed you out there. Sorry.
Yeah, okay, I shall pick this one up and then I shall pass over to Jocelyn Lyle from Internal Audit to take us through some of the key points of the report. So yeah, this is our annual or progress report on the Internal Audit annual plan work. Appendix 1 gives details of the reports that are being looked at in the current financial current year, and also some progress on each of them. But it's great to note that they're all on target at the moment. 4.7 onwards details or highlights the updates to the global internal audit standards, again, which that was introduced in April, and Jocelyn's going to take us through the key points of that. And section 4.15 provides assurance to PAC and to IJB in terms of internal audit reports that have been looked at through our partner bodies, NHS Tayside and Dundee City Council, that are relevant to the IJB for assurance purposes. Jocelyn, I'll happily pass over to yourself to take us through some of the key points of this.
Thank you, Jocelyn.
Thank you, Chair. Thank you, Christine. So I think Christine's probably covered the main elements of the progress report. Just to say that the internal control evaluation, which is a major piece of work, is with management for factual accuracy check and response, and that will be distributed to members when finalised, and that will then go on to inform our year-end work, which will be presented to the June meeting of the IJB and the September meeting of this committee. It's the same every year, just because of the timing. Happy to take any questions on the progress report and on the partner organisation reports. But probably the most important part of today's paper is the Global Internal Audit Standards. So just to give a bit of a quick run through of what's happening there. These new standards were introduced by the Institute of Internal Auditors in January 24, and they've been applicable for the public sector from the 1st of April this year. So those replace the public sector internal audit standards that we've been working to for a number of years. Those standards are supplemented by an application note for global internal audit standards in the UK public sector. And that was issued in December 24 by the relevant internal audit standard setters. For Scotland, that basically means the Chartered Institute of Public Finance and Accountancy, or CIPFA, and the Scottish Government. There's also a code of practice for the governance of internal audit in local government, and that addresses the responsibilities of management and the audit committee for internal audit. And that's just making sure that internal audit services have the necessary authority, support and oversight of the organisation. So that code also provides a link between recommended practices in the global standards and the established governance arrangements of local government bodies. So these global internal audit standards provide complete professional guidance for internal auditors, and they also set out the criteria against which we're evaluated. So the standards are based on 15 guiding principles across 5 domains, and each of those principles is supported by standards that contain requirements, considerations for implementation, and examples of evidence of conformance. So the main changes from the public sector internal audit standards to the new global standards are detailed at section 4.12. I think it is really important to say that many aspects of how internal audit operates won't change. We're currently complying with the previous public sector standards, and our working practices are in line with the intent of the new standards and with best practice. So really what we're doing is we're formalising our arrangements and overtly evidencing conformance during the year. And again, just to emphasise that conformance at the 1st of April was not required, but we do need to demonstrate that conformance as this year progresses. So just some of the key aspects of the changes. There's a requirement to develop an internal audit mandate. That's a new requirement, and that will sit within the charter that will be approved by this committee as it is annually. So that internal audit mandate sets out the authority, role and responsibility of internal audit. There's also a requirement for us to develop and implement an audit strategy, which supports the objectives of the organisation. And that strategy should help guide the internal audit service to fulfil our mandate. The standards also set out clearer roles and responsibilities for senior management and for the Audit and Risk Committee. And these are set out in section 4.14 of the cover paper. So, sorry, I just saw Dorothy's message. I think we did skip an item, and we'll have to go back. But if it's okay, Chair, I'll just keep going with the update. Thank you. So yes, so the new requirements for audit committees, the requirement to review and approve the internal audit charter, and that's reflecting your expectations of the internal audit service, and also a requirement for the committee to champion the internal audit function and support its purpose, strategy and objectives. So that's a really quick run through. These are lengthy standards. I think they're about 160 pages long. But all internal audit services are working this year to ensure compliance with the global internal audit standards. Since this paper was written, the FTF Improvement Action Plan, which is designed to demonstrate global internal audit standards compliance and also ensure that we progress recommendations from our recent external quality assessment, was approved by the NHS Tayside Audit and Risk Committee. That committee will monitor progress, and I propose that to avoid duplication of reporting, I'll provide progress, or rather assurances and progress to each meeting of this committee within just the standard progress report. So as I say, that's a very quick run through, but I'm happy to take any questions. Thank you.
Thank you very much indeed, Jocelyn. And with regard to GIAS, as I recall, I think there was a really excellent presentation that was done on GIAS itself that I think was really helpful. And I wondered if we could do this in one of our development sessions, just around some of the implications of this, so we could have a kind of fuller deep dive into some of the implications, because some of them are quite important. So could I make that as an action point, if that could be taken up, and we can see to having a presentation either at development time or added on to this meeting if we need to. But certainly I'd welcome that. Thank you so much indeed. Any questions for Jocelyn? Dorothy?
I would also welcome some, a presentation on this. I was looking at item 10 and this is actually item 11, so I'm a wee bit behind the curve here, but I did mark something on under the NHS Tayside reports table, page 116 of my bundle, 1, 2, 3, 5th paragraph down. Pace and urgency of the approach to financial recovery could be enhanced. The Sustainability and Recovery Group was formed in September 2024 with limited output to date, and a financial recovery action plan is not yet in place. Could someone comment on that, please?
Christine?
With this being a report that's gone to NHS Tayside, I'm restricted to actually seeing the sort of summary comments as well, so I'd have to go and have a look at the sort of fuller report or pick up from colleagues in NHS Tayside to understand the process there, unless Jocelyn can add any context or comment to it.
Just looking at it, I mean, I think the point that we were making is fairly clear in terms of, that everything has to happen at pace. There was a group that was formed in the September of 2024, and we were really looking to see the outputs from that. Now, this report was issued, I'm just checking when it came out. It was issued some time ago. In fact, it's just taken a wee while for it to get to this committee. So what I can do is take that away and check if that financial recovery action plan is now in place, and just feedback to on that, so I'm happy to take that as an action. Things may have updated since the issue of the report.
Okay, thank you.
If I can just add, obviously we have completed or NHS Tayside and the IGB and other areas have completed their 24-25 financial position and working through sort of annual accounts just now. I am aware that by the time NHS Tayside got to the end of the financial year 24-25, their financial position was considerably improved in the bottom line. But whether it's, how much of that's been the sort of savings and financial action recovery plan, and whether some of the key points raised in this has been in the internal audit report has been addressed, or whether there's been other things that's happened to change that financial position, and almost eliminate the need for the financial action recovery plan during 24-25. I'm not sure of some of the background, but I know that the financial position was much improved by the end of the financial year compared to what they were reporting partway through the year.
And Jocelyn, do you want to finish this one off? Thank you.
Yeah, thanks, Chair. I think just to add to what Christine was saying, we will be following this up through the audit follow-up system. We won't be doing a follow-up report for the June NHS Tayside committee because it's annual accounts and it's a really, really busy committee. So the next one will come through in August. So, those papers are in the public domain. You'll be able to see actions coming through there as well. But I will check to see where things are and see if things have moved on since the issue of the report. Thank you.
Thank you. We're asked to note this report. Thank you. And Arlene, item 11.
Right, so I think that was item 11, Chair, so we'll now need to go back to item 10.
Right, I see.
Okay.
Sorry, governance action plan?
For this briefly, so this is the now regular update on the progress against actions in the governance action plan. There's 4 actions that have been completed since the last update report, also 4 actions which have been added on. Those were the actions that arose from the workforce audit, which Pat considered at the last meeting. There are 23 actions that are ongoing, and 13 of those have had some level of progress since the last update was provided to PAC. Some that's been a small level, some a more significant level of progress, and those with that kind of greater level are highlighted in section 4.3. I think we're coming up to a period before your next report in September where we expect a number of actions to move on. There's quite a few in there that are tied to an annual review or an annual report. So this is a period of time when some of those will be able to actually be completed, that we've had to wait until that period to make an amendment or do something differently. So we'd hope to see a bit more movement between the May and the September report. And I'll just leave it there, Bob. If there's any questions, happy to take those.
Any questions? No. So we note the recommendations. Thank you.
I have a question.
Sorry, Dave's got a hand up.
Oh, sorry, Dorothy, I didn't see you.
Thank you, and thanks, Catherine. 8, there are 31 actions here, and 8 of them in the latest update say that action has been delayed by the 25-26 budget process. One of them actually as far back as October 2022, so I don't know how that works, but anyway. And it says these will be prioritised between April and May 2025. So 2 questions. Is this happening? And perhaps a comment. The budget process is an annual event. It's business as usual. And it's concerning that this caused so much disruption to normal workload. Was this year 25-26 budget more difficult, more complex, that it has caused that disruption to normal workload? That's my first question, Catherine.
Yeah, I'm sure Christine will comment as well, but I think 25-26 process was different for a number of reasons. Clearly the financial gap and the challenge around that, I'm sure Christine will comment on that, was significantly different from any budget we'd faced before. We also had a consultation process for the first time this year that we hadn't had before, and had to manage the capacity around that, Dorothy. And I know it won't be lost on any members here that took place against the backdrop of the risk on the risk register that you saw earlier, in terms of staffing capacity, and particularly the capacity in the senior management team, and the number of kind of temporary arrangements, etc., that are in place, and the reduction in overall capacity there. So you're absolutely right, that is a routine process that we can plan for, but this year was probably different, unusual, and hopefully exceptional in terms of future years as well, and that has had that impact. And you know, obviously the actions in the governance action plan are ones that we always seek to prioritise, but we continue to have that workforce risk, and particularly amongst the senior management team, in terms of pace of change around about that. As I said, I think some will move because it's a particular time of year when they can move, because there's some routine activity again that comes up that will allow us to complete some actions. But I'm sure Christine will want to add to that.
Yeah, I was pretty much going to say the same sort of things as Catherine's just pointed out. You know, the 24-25 has been an exceptional year in terms of our capacity. The fact that we were actually in financial recovery through most of the year obviously added to some of the challenges in terms of operational delivery and senior management and financial team support to this. And then the scale of the gap that we were facing, and the options and opportunities that we've tried to develop to manage that gap, and actually the pace and scale of actually delivering on these has taken its toll on our ability to do some of these, to progress some of these actions as well. So yeah, that the combination of a number of things all hitting us at the similar sort of time has meant that we've had to reprioritise workload within the capacity that we've got.
Thank you. Any further questions?
I do have one more, Bob, please.
Okay, Dorothy.
Thank you, Catherine and Christine. I appreciate that this last budget session was exceptional. And my query relates to action number 15. Overall assessment of progress in delivering the risk management action plan is included in the governance action plan, but the individual actions are not reported to the PAC. And the update says the annual report on risk management arrangement is submitted to the IJB, and next report submitted for April 2025. So it's submitted to the IJB annually, but the action is to report individual actions to the PAC. So I don't think the update actually does what the action asks.
Yeah, I think the level of completion reflects the fact that we acknowledge that, you know, there has been a level of progress in terms of making sure that the risk management arrangements are reported to that IGB in one of its committees, if you like, but that we've still got work to do. And I think there is an issue there in terms of further discussing that. Claire leads on that area with Christine and potentially with audit colleagues as well, about what they would expect to see in terms of PAC reporting around about that. Obviously, we have a report on the risk register that you've seen today, but it may be that we need to think about other aspects of the kind of risk management part that need to be reflected in that too. So I think that we're just reflecting there's been a level of progress in terms of the IGB overall, but I agree there's more work to be done around the PAC element, Dorothy.
Okay, thanks, Catherine.
Okay, thank you. So no further questions. So we note this report. Thank you. Thank you very much indeed. I appreciate the pressures that staff have been under to follow up on much of this. And again, it just highlights some of the issues around about risk that we've been stacking light with key staff here to do some of this work. So I know it's not a full mitigation, but it is an important element of this. Thank you. And Arlene?
That takes us on to item 12, which is the attendance list, which is submitted for information and record purposes. And then item 13, which is the date of the next meeting, which is the 24th of September.
Okay. Thank you very much indeed. Thank you. It's been a kind of fascinating, but thank you so much indeed for the amount of work that's been put into the paperwork, and also for the discussion as well. Clearly a lot of work to do, particularly around the GIAS stuff, which I think is actually quite dynamic. I find it quite interesting, actually, Jocelyn, I have to say. But thank you so much indeed. Okay, I'll see you all in September. Thank you.